There are very well reported problems associated with assessing the cost effectiveness of public health interventions. Now, the way we do it at NICE is we use a standard set of methods to assess cost effectiveness, the main one of which is called cost utility analysis, the familiar measurement of the quality adjusted life year, which considers the quality of life of someone that they'll experience, as well as the extra life they will gain as the result of intervening in a particular way. When NICE began, it focused only really on the cost to the National Health Service. Once we took on a public health role, we extended our reach rather further to include the whole of the public sector, and also in certain circumstances other aspects where costs and benefits might be borne. But what we don't do is we don't include the costs of lost production due to illness or incapacity. The time horizon for working out these costs and benefits in most cases is the lifetime horizon, with an annual discount rate of 3.5%. The general rule is that we use, where an intervention is calculated to cost less than £20,000 of QALY, although formally there isn't a threshold, but that's roughly the sort of area where we seek to determine whether something is or isn't cost effective. Interventions which cost between £20,000 and £30,000 QALY might in certain circumstances be recommended, and if it's over £30,000, it's generally a no. Perhaps the easiest way to see what all this means in public health terms is to look at this graph, which measures on the y-axis the chances of us rejecting an intervention, and on the x-axis the cost per QALY. The red is where we definitely say no, the browny colour in the middle is perhaps, and the green a definite yes. The public health work that we've done over the years has found that public health interventions, generally speaking, using this kind of approach are highly cost effective. To what degree does that help a local decision maker, someone commissioning at local level? Can you apply this if you are looking at local decision making? In July last year, we were asked to develop a prototype model for local authority commissioners to show the potential return on investment for health improvement interventions. The first stage was to examine current practice and explore and test other methods for assessing the cost effectiveness and cost impact of public health interventions. And we used a range of mixed methods, primary research methods, to find out. In a series of workshops we conducted, we found that decision-making at local level, for the most part, was not informed by economic considerations, was not really informed by any kind of cost-utility sort of approach, but instead used a range of rather imprecise ways of thinking about the problem. There was certainly a lack of strong partnership working between the health sector and local authorities. We asked in our workshops for the participants to rank, in terms of decision making, 14 different criteria, and views varied very widely across health sectors. And of course this is one of the key problems when you begin to think about outcomes. Whose outcomes and which outcomes get valued most? So for example, when we asked about what value or where people would place impact on health inequalities of interventions, for local authorities that tended to be first, but in the health sector it only ranked fourth. Effectiveness, does it work, was ranked anywhere between first and seventh by participants in the health sector. Cost effectiveness, is it good value for money, was ranked anywhere between first and 12th in local authorities. So what you have here is not an economic calculus working through, or even an effectiveness scientific calculus working through. You have you have a range of different things coming into play. And by and large, most of the investment decisions were being made, or the commissioning decisions were being made, on the basis of what they did last year with a margin of change. What we think is important is to be able to report health and non-health outcomes, the social and other outcomes, and their costs in a disaggregated format. Second, we need to report return on investment in the short, medium and long-term time horizon. And the way we illustrate this is to develop what we call scenario analysis around different intervention options. We've reviewed existing models and costing tools to supplement what we did originally to try and pull together something that is a workable economic model, that's something that isn't so complicated that no one would ever use it. I want to end by talking about the key challenges of unravelling all of this. First of all, cost utility analysis, although it doesn't figure at more than about a quarter of the literature in return on investment, is the dominant metric in health economics. So there's a bit of a disjunction between what health economists are doing and what we need to know in terms of local-based decision making. Second, in the new providers and in the old providers, in PCTs too, or the new providers and commissioners, there is the use of many other metrics other than health economics. We have this major problem of the cross-sector flow. One sector paying for it, another sector benefiting. We certainly need a sound basis for resource allocation in the time of scarcity, and the problem is now more acute than when we began this work in 2010. What is clear, however, underlying all of this, notwithstanding my apparent critique of the cost-utility approach, what the cost-utility approach demonstrates absolutely unequivocally is that this is good value for money, if you like, at national level. And we really need to find ways and means of reinforcing that message. The time horizon is significant. Many of the things that we're talking about here don't deliver financial savings immediately. Though interestingly, they do deliver health savings, sometimes very quickly indeed. And therefore, the rates of discounting which the Treasury impose on many public sector decisions at least have to be worked through in a sensitive sensitivity analysis to help us get to that point.